Healthcare disparities are a major problem in the United States. In this video, we will be addressing how different types of biases in healthcare providers influence the quality of healthcare delivered, as well as variations in diagnoses. In 2017, a review of 42 articles by Chloe Fitzgerald and Samia Hurst compared implicit biases between healthcare professionals and the wider population. They found that both populations shared similar degrees of implicit biases in qualities such as race, gender, socioeconomic status, age, and more. In a clinical setting, the degree of implicit bias also negatively correlates with patients' ratings of quality of care. Intersectionality of multiple patient characteristics can also influence how patients are treated. For example, bias against females has been well documented in clinical settings. Despite sharing similar symptoms, men are offered more thorough diagnostic testing and extensive treatments. For example, when diagnosing coronary artery disease, physicians are more likely to recommend catheterization to men than to women, despite similar abnormal results from preliminary tests. A similar study showed that discrepancies in diagnostic testing between males and females persist even after controlling for risk factors and patient characteristics such as age and race. Physicians are also more likely to interpret men's symptoms as biological and women's as psychosocial. A study by Bernstein and Kane asked 253 primary care physicians to review simulated cases that varied by patient sex, presenting complaint or exclusion of a personal problem. They found that significantly more physicians anticipated excessive demands on physician time from females than from males. Physicians were also more likely to interpret females' complaints and symptoms as psychosomatic or influenced by emotional factors. However, it may also be of interest to note that when men are more expressive about their personal problems, there is also a greater increase in physicians' psychosomatic diagnoses than compared to when women are more expressive of their personal problems. In terms of race and ethnicity, while explicit bias is not always apparent, implicit bias has been shown to exist to varying degrees in physicians. Studies show that physician bias can have effects on the quality of care delivered. In a public survey done by the Kaiser Family Foundation, a large proportion of African Americans and Latinos reported having experienced or knowing someone who has experienced unfair treatment when seeking medical care due to their race or ethnicity. A study published by Green and colleagues in 2007 showed that not only did physicians hold implicit racial biases, these biases contributed to differences in whether physicians decided to perform thrombolysis for patients with myocardial infarction. As pro-white bias increased, the likelihood for treating white patients and not treating black patients with thrombolysis also increased. Varying levels of healthcare quality can also depend on the socioeconomic status of a patient. Multiple studies have shown that those with lower socioeconomic statuses report greater discrimination and lower quality of care. They also receive less preventative care such as mammograms and prenatal care, and more avoidable procedures such as amputations. However, differences seen due to socioeconomic status may be confounded with other factors such as race and access to health care.
The following are interviews we obtained from a patient and physician. The names in these interviews have been removed to maintain participant confidentiality. Patient X is a real-life patient from Los Angeles, California. He is a real victim of racial discrimination in medicine.
The summer before my senior year at UCLA, I began to feel sick. This was a different type of sickness from which Alexa had never felt before. It first began with migraines, which did not allow me to leave the bed, forcing me to miss my classes and several days of work. The next symptom was a complete loss of appetite. I lived off Ensure for a week, and even that was difficult to keep down. I often crouched near the toilet consuming Ensure, and I felt nauseous to the point I thought I would throw up every time. One night, walking home from work, I threw up the intro I had consumed during my shift. I weighed myself that night and saw that I went from 180 pounds to roughly 155 pounds in a matter of a couple weeks. This is when I decided it was time to see a doctor. The first doctor I saw, a Kaiser Permanente, did not seem to take my symptoms into much consideration and quickly dismissed it as my possibly eating something bad and advised me to just relax for a few days and take some over-the-counter aspirin. I could tell she wanted me out of the room quickly just from how fast the entire appointment was. I did not feel satisfied with the doctor's answers and attitude, so I decided to get a second opinion. The second doctor, before I had even finished describing my symptoms, jumped to the conclusion that it was a sexually transmitted disease. I had reassured him that it was most certainly I was not sexually active. However, he aggressively said something to the tune of, "Look, you're a young man, going to UCLA, you party, you drink. Come on, man, sounds like an STD to me." The nurses agreed with him, and I pushed back again, and I said, "No, I don't party, I rarely drink, and if I do, it isn't much, and I am not sexually active." I've never heard of a doctor talking to a patient the way he talked to me, which left me very confused and as if my sickness was not serious. He repeated what he said and absolutely wouldn't take me seriously, after I had told him how sick I felt and asked him to check if it was something else. He dismissed it all and proceeded to order blood tests of every type of STD you can imagine, from mono to HIV. I couldn't help but feel he was judging me for my appearance. As a young African-American man, I felt as though he thought I wasn't telling the truth. I am an immigrant from Ethiopia, and I believe he saw my vaccination or patient history, which leads me to think which was one of the reasons in ordering an HIV test. I was very irritated, and he would go as far as to order so many blood tests and thought I had HIV was necessary, and by constant reassuring that I was not sexually active. I had told my parents about my appointment, and they were furious. My mother has horrible anxiety and was distraught from the thought of me having HIV. Both my mother and father agreed that the doctor was not professional and that he jumped into a conclusion and didn't believe me because of the color of my skin. My experience made me think about the time my father had cirrhosis of the liver. He lost 60 pounds, he was practically skin and bone, and the nurses treated him and my family with so much disrespect because they had assumed it was caused by alcoholism. They treated my mother like she was a victim, they wouldn't talk to me or my brother, and every time we visited his hospital bed, I could feel the stares and judgment from them. My father had cirrhosis caused by hepatitis, and after they had found out alcoholism wasn't the case, they immediately started treating us differently. In another instance, at my community college, I wanted to donate blood. The first question I was asked if whether I had AIDS. None of my peers were asked that. I thought it might have been protocol, but it was not the case for them. I began to wonder if it was because we were black that we were being treated this way, and asked questions nobody else would get asked. That everyone simply assumes the worst in us, which leads them not to believe our word. When my blood test finally came back, all negative of course, the doctor personally called to apologize and go over my results. It was not news to me, and I refused to go back to someone that had treated me with such disrespect. Eventually the symptoms went away, I gained my weight back, and I never found out what happened to me. I did not have the confidence to go to another doctor because I thought I would get treated like the previous doctor treated me, or like how my father was treated.
Unfortunately, stories like the one our patient just described happen every day. But if that wasn't convincing, a study done by City University at the New York Medical School on racial and ethnic disparities suggested that provider and institutional bias are the most significant contributors to racial and ethnic disparities in American healthcare. In fact, there is a plethora of evidence and support, such as when, compared with whites, blacks and Native Americans are less likely to receive transplants and are less likely to be put on a waiting list for transplants. If they are waitlisted, they wait longer before receiving a transplant. Furthermore, economic barriers seem to be the least likely. These racial differences have been found in both private hospitals and in VA hospitals where care is free. In psychiatric care, for example, African Americans are more likely than whites to be diagnosed as psychotic, but less likely to be given antipsychotic medications. They are also more likely to be placed in restraints or isolation, differences that are found at every age level and in both outpatient and inpatient services. Now, onto a physician interview. they also witness biases from other physicians too. Unfortunately, stories like Dr. E's are not unique and happen all the time. Dr. Monique Tallow describes us a patient that recalled, "They treated me like I was trying to play them, like I was just trying to get pain meds out of them. They didn't try to make any diagnosis or help me at all. They just couldn't get rid of me fast enough." Most physicians are not explicitly racist and are committed to treating all patients equally. However, they operate in an inherently racist system. Indeed, it is this inherently racist system, coupled with our implicit biases, that leads doctors to give biased medical diagnoses. Patients of color feel that they are unwelcome, uncared for, and just flat out denied when they seek medical attention or diagnosis of a new or pre-existing condition. And of course, the 2016 election does not help with that. This can lead patients to grow resentment toward healthcare physicians and providers because they feel that their word as a patient cannot be trusted, which in turn could make patients stop seeking medical care. This can be very detrimental to their health and lead to an overall decrease in the quality of life.
Tackling the issue of bias and discrimination in healthcare is therefore an important but somewhat difficult task. Research in the past few decades has turned its attention to neuroscience in an attempt to clarify how we develop certain biases and perhaps how we can use our understanding of neurobiology to alleviate them not only in medical practice, but in society as a whole. Now, despite the cultural and social aspects that contribute to our prejudices, these behaviors develop naturally as a tool used to maximize efficiency by the brain. Being the social animals that we are, a fundamental part of our interactions with others is the ability to quickly recognize other people and discern whether they are familiar, safe, unknown, or possibly hostile to us. In order to make such decisions quickly, the brain utilizes the information readily available, which may include race, age, gender, and other physical characteristics. These contribute to a method of decision-making that our brain uses automatically called heuristics. We make decisions based on a rule of thumb, or based on our previous experiences within similar parameters, rather than assessing the entire situation every time. On a day-to-day basis, this saves our brain a lot of time and energy. It takes shortcuts, using that information to make the decision-making process easier. However, this is also how we develop biases and prejudices towards other people. Because it would take too long to strike up a conversation and figure out the background work, hobbies, and values of every person we pass on the street, the brain decides to settle for simpler characteristics that can help us reach our judgment faster. On a fundamental level, this is useful to us, but in other situations that require thoughtful care and analysis, such as diagnosis and treatment of medical conditions, defaulting to our internal stereotypes can be detrimental. So how does the brain actually make these distinctions? Well, a common idea that attempts to classify cognitive processing, called dual process theory, shows up frequently in research analyzing medical decision-making. Under this theory, there are two different cognitive systems our brain uses to make decisions. System 1 is our intuitive or pattern recognition system, a subconscious and more or less automatic process. When problems are routine and we're working under a time constraint, we use System 1. That's not to say that it's unreliable or inaccurate. In general, our reflexive thinking serves us well, and indeed, much of the prior experience that contributes to System 1 processing is adapted from slower, more analytical decisions we've made in the past. Over time, we integrate these concepts from System 2, and they become more routine, such as a physician gaining experience in diagnosing certain medical conditions. However, until such decisions can become reflexive, we use System 2, the more analytical and deliberate alternative. This method requires logical judgment and a conscious search for additional information that will aid in the decision-making process. Although slower and more cognitively demanding, this process usually results in better decisions. A study of second, third, and fourth year medical students in 2016 showed that up to half of the students either partially or fully relied on System 1 when making medical diagnosis decisions, while a full 10% used System 1 exclusively to make medical decisions. This led to choosing answers on a cognitive reflection test that were intuitive but incorrect and would result in diagnostic errors in real life. Thus, many medical schools have started to incorporate instruction into their curricula that promotes awareness of cognitive biases in medical practice and encourages uses of System 2 processing when making such important decisions. Although the brain regions specifically active in each respective system have not been classified distinctly, a number of studies in the past 2 decades have identified brain regions associated with the development of bias in our interactions with others, and these pursuits continue today. Key regions include the amygdala, fusiform gyrus, orbitofrontal cortex, insula, striatum, and various parts of the prefrontal cortex. Of these regions, the amygdala is perhaps the most studied, as it has long been known as a processing center for emotion, and the lateral amygdala receives inputs from all our sensory systems. As a result, it is constantly implicated in fast, automatic evaluation of socially relevant stimuli. While the amygdala is most commonly associated with fear, it is responsive to both negative and positive inputs and helps shape our reaction to incoming stimuli. Studies in racial bias have shown greater responses in the amygdala when presented with faces of a person's outgroup versus their in-group. This is commonly seen as an extension of our natural methods of detecting threat or reward. The fusiform gyrus also aids in these functions, as this is the brain region responsible for recognition of faces. Next, the insula and striatum work in concert to develop our reactions to stimuli. The insula generates our visceral reactions, such as fear or disgust, and its activity has been frequently implicated in reactions to racial outgroups versus in-groups, usually reflecting implicit negative attitudes. The striatum, on the other hand, is involved in the assessment of value and anticipating outcomes. In studies of bias and preference, it has shown increased activation in response to one's racial in-group, suggesting a role in guiding positive intergroup interactions. Now we move to integral parts of the frontal cortex. This is where a lot of our higher order processing occurs. In the social domain, the orbitofrontal cortex supports the monitoring of social cues and subsequent adjustment of one's behavior. While this region is interconnected with other, more fundamental emotional response centers, such as the amygdala and striatum, the orbitofrontal cortex works to modulate our response based on what is socially acceptable. In fact, it has been implicated by some studies as a center contributing to deliberate decisions to befriend or work with members of one's outgroups, and in assessing group membership based on factors that move beyond race. As for the prefrontal cortex, this region has a wide variety of functions contributing to implicit bias, but also helps to modulate our responses and control what we express to others. For example, the anterior cingulate cortex processes conflicts between our internal biased tendencies or expectations and external cues. This region is active when we encounter situations that go against social norms. For example, one study showed significantly increased activation in the anterior cingulate cortex and surrounding regions when subjects were presented with statements that were incongruent with traditional gender stereotypes, such as women in engineering or men doing housework. Finally, the medial prefrontal cortex is important for processing social information. It is known to play a significant role in forming our judgments of other people based on what we know about them. Because this brain region takes into account more than just the initial sensory cues we receive about other people, it is considered part of a humanization process, and by extension an important factor in developing empathy for others. Therefore, this is a brain region associated with executive processes that allow us to overcome more fundamental biases. However, it does still contribute to our identification with in-groups and out-groups. One study of empathy showed that the anterior cingulate cortex and medial prefrontal cortex were only activated when viewing painful stimuli applied to one's racial in-group, with decreased activation when the same stimulus was applied to members of another race. In this way, we see that a number of different brain regions interact to form our implicit biases, which in turn affect decision-making in important fields such as medicine. There are still more areas that contribute to smaller details of developing biases and which exert executive control over our reactions. The precise workings of these circuits have yet to be uncovered, but with the availability of fMRI and EEG technologies, scientists are making significant progress in identifying correlations between activated regions and social behavior. There have even been recent advances in learning and memory research that may allow us to manipulate these implicit biases and thus intentionally modify the way we subconsciously perceive the world around us. These advancements can certainly lead to improved outcomes in the medical field as doctors become more aware of their implicit biases and take steps to minimize them in practice.
Biases in physicians can lead to a variety of consequences, including diagnostic errors and poorer quality of care. These in turn have impacts on patients' perceptions of healthcare, whether they choose to seek treatment, and more. Cognitive biases in physicians can lead to inaccurate diagnoses. Specifically, a review of 20 studies found that biases such as overconfidence, lower tolerance to risk, the anchoring effect, and information and availability biases contribute to 36.5 to 77% of diagnostic inaccuracies. These errors can potentially have severe impacts on patient well-being and hospital expenses. Patient characteristics and physician bias against these characteristics can also influence how patients rate their physicians and quality of care. In a study of clinicians' implicit ethnic and racial biases, higher IAT scores against Blacks correlated with lower predicted ratings from Black patients. On the other hand, Latino patients provided low predicted ratings regardless of the clinician's IAT scores. In addition, perceived discrimination also affects whether patients choose to seek treatment or not. A Swedish study found that those who experienced more discrimination were more likely to avoid seeking treatment. This effect was further magnified when socioeconomic disadvantage was taken into account. Other studies have shown that perceived discrimination correlates with patient-provider communication. For example, African American patients who reported greater perceived discrimination showed less positive nonverbal communication, even though verbal communication did not differ. Patient-provider communication in turn affects adherence to medical treatments or advice. Positive communication methods, including effective transmission of information and inclusion of patient in decision-making, are correlated with higher rates of adherence. Poor communication, however, can increase the risk of patients' non-adherence. All of these factors in turn have consequences for patient health outcomes.